Okay, so I think we'll begin. Thank you so much, everyone, for joining us today. My name is Amy Sam. I am the Health Education Project Specialist at the Maxwell Eleanor Blum Patient Family Learning Center at Mass General Hospital. Today's program is a special collaboration between the Blum Center and Corrigan Minahan Heart Center at Mass General Hospital. Before we begin, just wanted to go over a few items with you all. Please note that today's session is being recorded for educational purposes. If you're interested in viewing the recording of today's session, feel free to visit our Blum Center website at massgeneral.org/Blum-Center. Everyone is in listen-only mode. Everyone has been muted so that we can hear our guest speaker today. If you have any questions, please use the chat feature, which is located at the bottom of your screen. We'll have time for them in the end. Only Blum Center staff and the guest speaker will see your questions. Please do not share any personal medical questions or information in the chat box. If you have a personal medical question, please ask your doctor. Stop sharing. So Dr. Learn, would you like to pull up your slides?
Okay.
So next, I would like to introduce you all to Dr. Christopher Learn. He is a cardiologist at Mass General Hospital. He is board certified in internal medicine, general pediatrics, cardiovascular medicine, pediatric cardiology, adult congenital heart disease, and adult echocardiography. In observance of American Heart Month, which is February, Dr. Learn joins us today to give a presentation on transition to adult care for those living with congenital heart disease. So please join me in welcoming Dr. Learn.
Thanks very much. And I'm very happy to talk to you guys today. So I'm going to be talking about transition, and in kind of modern academic medicine, we're supposed to let people know if we have any disclosure, if we have any financial conflicts of interest. And I have no financial disclosures, but I will admit that my topic is sometimes hard to talk about because the term transition does not always mean transition. And what do I mean by that is that if you look in the medical literature, if you go onto Google and you try to search for this topic, it can be complicated because transition in medicine can mean changes in demographics over time, like how is the health and population of the city changing. Very frequently, it's used to talk about transition from hospital to home. So as somebody is getting over an acute illness and making that transition from going from in-hospital care to at-home care with clinic or visiting nurses, that's a common area of academic interest. There's issues with doing like transitions between consciousness and sleep-wake and different kinds of cell types. But what we're talking about today, and kind of the medical search term, if you were going to try to look at that, is typically what a lot of people call transition to adult care, or pediatric to adult transition, or adolescent transition. And I don't want to get too nitpicky about the words, but it does sometimes matter a little bit in how we're talking about these things to try to be consistent, and so people kind of understand what we're talking about. What is this, why are we talking about transitioning from pediatric to adult care? Well, this is an issue I work in the world of people who are survivors of congenital heart disease. So they were born with something that was different about their heart. They probably put their heart at a little bit of it, or maybe a big disadvantage. And this is a graph that shows the odds of surviving to 18 years of age with you were born a congenital heart defect. In the 1940s, for most of the significant forms of congenital heart disease, only about 20% of patients made it to age 18. With the advent of the early surgeries and early better hospital care, the survival rate by the 60s got up to 40% of those patients would make it to age 18. There were big advancements in the 60s, 70s, and 80s, so that by the 70s, 75% of those patients were making it to adulthood, and kids born in 1980, 90% of them with congenital heart disease are making it to adulthood. And that's just kind of looking at kind of, mild, medium, and severe forms all lumped together. If you look at the most complex forms of congenital heart disease, often where one side of the heart is severely underdeveloped, in the 40s, only about 5% of those patients would make it to adulthood. And there was a little bit of improvement by the 60s, but by the 70s, we saw some big strides, and by the 80s, some really big advancements. So now, and the numbers have continued to only improve by then. So basically, the expectation is that the vast majority of patients that are born with complex congenital heart disease are going to make it to young adulthood. So this is a great problem to have, but it's sort of shifting the demographics. Because if you looked at, in 1965, of all the people in, say, the United States who had congenital heart disease, there were a bunch of kids and relatively few adults. And by the time that you got to the mid 80s, there were more kids living, but there were also a lot of former kids who are now over 18 and older. And by 2010, there were still a lot of kids living, but now the number of survivors from past decades actually eclipses the number of kids living today with congenital heart defects. So it's becoming much more of a condition that really spans the age spectrum than it used to 25, 30, 40 plus years ago. But along with that, we have other problems where a lot of people who were diagnosed with congenital heart defect are no longer necessarily seeing a cardiologist. This was a study that was done out of Canada that looked at kids who were under 6 years of age, and they said, okay, let's see how they do over time. So they said 643 kids, and they said, okay, and they're under 6. So how do they do from 6 to 12? Well, by age 6 to 12, only 64% of those patients were still being seen by a cardiologist. By age 13 to 17, only about half of the original patients were still being seen. And by 18 to 22, it was only about 39%. So just under 40%, basically 6 out of 10 of the original kids were no longer in the care of a cardiologist. And you could say, well, maybe is this because they moved away or they no longer live in the area? Did some of them pass away from a heart condition or something else? Well, this is looking at the trend for how these patients were kind of falling out of the practice over time. So it starts with 100% of the patients, and it's a fairly linear kind of straight line to age 18, where about 39% of those patients were still in care, and about half the patients were lost by just over between ages 14 to 16. But because it's Canada and they have province or kind of statewide medical records, they could look and see if these people were still alive or they're still around. And 87% of them still had contact with their primary care doctors. And if you can include emergency rooms and any kind of health providers, 93% of them patients still had some contact with the healthcare systems. So it's not as though that they all moved away or they all passed away. A lot of them just stopped seeing the cardiologist. And some of that, there are a lot of reasons potentially for that. A lot of people may think that they are well, and they may actually be doing pretty well, but there are potentials for later issues in life that we try to keep an eye on. So there's this kind of, at some point as people get older, there's often this transition where we start with a pediatrician who's often very nice and friendly, and the doctor that people grew up with, and then at some point, you move to an adult doctor who maybe has a slightly different attitude and a different kind of care setting. And there are wide variations in terms of how pediatricians and adult doctors interact, but the systems are, in general, there's some kind of cultural issues. Pediatric practices tend to be very family-centered, and adult practices tend to be more about the individual person. The pediatric practices are developmentally oriented. In other words, they expect that there's going to be a big change from a patient that starts in their practice as a newborn and grows up with them. And so they're kind of a sense of kind of following that patient longitudinally over time and expecting big changes on how they interact with things. And in an adult practice, you're mostly dealing with all adults, and it's more focused on the focusing of the care of the disease or the issue. Pediatric practices are often very nurturing and supportive, and adult practices are much more like, I'm going to try to give you the information so you can make the best decisions about what you feel is best for your care. This is not always true, but pediatrics are sometimes very interdisciplinary, and like they coordinate with a lot of different providers in different specialties. Adult providers, it's sometimes there's a lot of care at different sites and with multiple disciplines, but it may not be always as coordinated. And for kids, obviously, the parents are directing and signing consent forms and all this, but in adult practices, it's sort of left to the individual to do what they want to do. And it's good to have autonomy, but it's also, a lot of us aren't always perfectly great at taking care of ourselves, but it's sort of, we're corresponding typically directly with the person rather than with their loved ones, unless they direct us otherwise. So you might say, well, maybe I like that environment of the pediatric group. Why shouldn't the patients just stay in pediatric clinic for their whole lives, especially since maybe adult providers are less familiar with congenital heart disease as a whole? Well, unfortunately, life also throws us other medical issues. So definitely for women, after they go through puberty, there's all sorts of issues related to gynecological care, whether it's dysfunctional uterine bleeding, pregnancy, contraceptive issues, for men and women, issues about sexual health, depression, anxiety, obesity, diabetes, having high cholesterol, substance abuse issues, cancer screening, health as it relates to occupations and workplace exposures. And not that pediatricians can't tackle some of this, but very rarely will any single adult doctor try to tackle all of these things. We kind of usually work collaboratively with different people to try to handle all these potential issues that come with being older. And adult providers often have a lot of direct experience with the exacerbations of chronic conditions in adults. So, I and my colleagues who do adult congenital heart disease are often very familiar and have a lot of firsthand experience in dealing, say, a woman who had born with a congenital heart defect and is now an adult and now pregnant. And that sort of overlap of things. Pediatric cardiologists are often extremely comfortable with the heart and the physiology of the heart and the surgeries and things to correct it, but they may not have seen that many patients unless they followed them for a long time who've had the kind of stresses and joys of pregnancy on top of that. And then we also have the adult providers have access to adult inpatient teams and subspecialists. So, if somebody got arthritis on top of their congenital heart disease, I could know about a rheumatologist to send them to try to help them get other adult specialists involved in their care. And then the other thing that a lot of times that we get back into the semantics, the word choices for all this, is the distinction between transition and transfer. A lot of times we talk about transferring care versus transition, and people who write about this in a thoughtful kind of academic way try to distinguish transition as more of a long-term process of achieving independence in healthcare management, decision-making, and then ultimately transferring the care. And the transfer of care is kind of that point where you switch from pediatric to an adult provider or setting. So again, the transition process, if you were to think about it, is something that kind of starts on, kind of childhood to early adolescence, kind of laying the groundwork. And then by a lot of places will aim for age 16 to 18, maybe 21 to transfer. In here, it's adult congenital heart disease care. But these same sort of issues apply to other sort of health conditions. So there are a lot of kids who are not born with, but develop in childhood, say type 1 diabetes, or they have to start taking insulin at a young age, or a child that's born with cystic fibrosis, or other sort of health conditions that they start out either at birth or earlier in life, and they have to learn how to handle it as an adolescent, and at some point they will likely transition to an adult provider. So this is also happening on the overlay of growing up. So there's a lot of transitions in life. There's kind of, for many of us, it's going off to school. For some of us, we either go to school and then get a job, or others just go straight into the job market. Moving out of our parents' home and getting a place on our own is a big transition. And often these things go well. We sometimes get our degree and get a job and, maybe start a family of our own and in pregnancy. But, sometimes things don't always go perfectly, and the job market stinks, and you're in the middle of a pandemic, and you end up with octuplets instead of a single pregnancy. So even though we try to prepare for these things and we think might happen, we don't always know what's going to happen to us in life. And there can be problems in terms of, substance abuse and all the other sorts of things, risk-taking behaviors that are a normal part of adolescence and growing up, but can pose challenges for people who have chronic health conditions. So we have to kind of be mindful of all these things. In terms of like the tasks that we all have as we grow older that we try to achieve is we try to, even if we live and care with our parents, we still try to achieve some independence where we start making more decisions on our own. We hopefully develop a healthy self-image of ourselves. And for most of us, we have, goals about our education and what kind of jobs we're going to pursue. And most of us hope to achieve, some financial independence where we can sort of, make enough money to support ourselves and do prioritize the things that we want to do in life. For many of us, we want to live independently, and a lot of us will want to have a marriage or a partnership and participate in our broader community, and ultimately to hopefully have good mental health at the end of the day. And the transition from childhood to adulthood varies and can take a lot of paths. So this was a study where they looked at different, large group of people and see how different paths people take. About 40% of people went to college and lived on their own, got a career, and were looking for their problems. So they were single but educated, had gone through higher education. Some people had been, educated partners. They got married, went to college, got married, and living on their own, starting a career. Some people had only completed high school. They weren't in significant involvement. They hadn't gotten a job yet. Some people were fast starters. They went high school, they got found a partner, lived independently, got a career, and started parenting, skipped the college thing altogether. That was about 10% of people. Another 10 did high school, found a partner, lived on their own, but were having problems with the job market. So there's different paths. We don't all follow the same path, and different ways may pose different challenges, whether you're having starting a family early in life or focus more on school or career, or whether or not, again, right now with the pandemic, you might aspire to do these things, but it's just tough. And you might just be kind of at home waiting for the next stage of life. And as you're trying to do all this, you may be trying to manage a heart condition at the same time. So, what if the transition things don't go well? Well, there's potential downsides health-wise. There's also things if we don't, as providers, if we don't communicate people's healthcare, needs and things that we have to watch out for. If we don't express that accurately, that can lead to downsides. So, some people said that, they said, I would be fine once reaching adulthood. And this was a patient who had tetralogy Fallot and later in life developed a significant heart rhythm problem and received a defibrillator. And it is true that most patients with tetralogy Fallot don't necessarily need that. It's one of the reasons that we do continue to keep an eye on people as they get older. It's just to keep an eye out for some of those patients who will maybe develop some of the risks that not everybody does, but we see enough patients for that we know that we need to be vigilant. They said after my surgery when I was a kid, my heart was fixed. And this was a gentleman who had detransposition of the great arteries, which is where the aorta, the artery of the body, and the pulmonary artery, the artery to the lung, started off in the wrong position. And later in life, he ended up having to have catheter procedures and a pacemaker placed. And so we've gotten, I think, pediatric cardiologists who take care of kids today have really gotten very careful with their messaging to say that, that we did a surgery and your heart's better, but this is a lifelong condition that is going to need follow-up. And even if you feel great, there's, some things that we need to keep an eye on. We want people to feel, a sense of normalcy and not necessarily always worried that there's going to be a health problem in the future, but we also be very clear that they can't think away that it's just simply done. It's a one and done sort of thing. There are a few conditions where, the risk of long-term issues are so low that might be true, but we often err on the side of keep people in care. On the flip side, this is a woman who said, I was told initially that I would die if I got pregnant. So I had my tubes tied in my 20s. But since having my valve surgery, my heart's improved. So now I wish the tubal wasn't so permanent. So you can go the opposite direction where you can maybe warn somebody too aggressively that they're going to have big problems and they shouldn't take risks. But as our field has developed, we have learned that for many women, if they are doing well with their heart condition before pregnancy, and if they wish to get pregnant, usually it's something that we can navigate with a really minimal or modest risk to them. There are exceptions, but a lot of the conditions that we used to think were really, really high risk, we're now finding out are not so high risk, and or at least that the risks can be often navigated. And so that hopefully, if this is very important, that's something that somebody wants to do, we can try to find a safe way of doing it. So, as we grow older with life, we try to hopefully pick up skills, and the same thing sort of happens as we sort of engage and interact with healthcare systems. So it's like when a lot of people, when they go off to college, if they haven't done laundry before, they might slip a red sock in there and then suddenly get a load of lights this morning. And it says, some of it just say give it to your mom. She knows how to do it. So there's some things that we pick up along the way that a lot of us are, we get taught by our parents or by friends, but the part about how to become an independent adult with a long-term health condition is not always something that's explicitly tackled. There's, unlike learning to drive, where hey, you're turning 16, let's get your learner's permit, let's I'm going to take you out the first time and help set you up how to learn how to do it. We often don't have the cultural or structures around this sort of things for people with a chronic condition, say like a congenital heart issue. So when we try to do this education portion of things, we try to have people try to learn about their heart, learn where it is now and what it needs now, and then what it may need or what possible issues they could see as an adulthood. Trying to learn the importance of responsibility for healthcare and how to talk about your concerns to your cardiologist and other healthcare provider. A lot of people are not clear on how to voice their concerns. They have some discomfort about, how do I advocate for myself? Learning how to take the medications as prescribed, and that doesn't mean always doing exactly what the doctor says. If somebody has a concern about a medication and some aspect of their health, or if they think there might be a side effect, how to communicate that back to the doctor and know when should you put up with something and try to stick with it versus when is it safe to stop it? Or if we stop it, do I need to replace it with something else? How to monitor the treatments and parameters of people's health and general information about birth control, pregnancy, and childbearing. This also applies for men and women because some heart conditions there's an inheritance risk. In other words, the odds that you might pass it on to future kids is higher than with other ones. And that may inform people's decisions about how they would want to start a family if they want to have kids. One of the key things is trying to learn how to be able to recognize signs and symptoms that require urgent attention. Like, what are the things that I can sort of keep an eye on or I'll bring up at the next visit versus what's something that I need to pick up the phone and call. And then also to help understand what sort of things do I talk to my primary care doctor about versus do I talk to my cardiologist or do I need to go see an emergency room person for? There are some guidelines. So the American Heart Association a number of years ago tried to lay out some of what they thought were some of the best things to try to look at the available research and medical literature, and then also just the things that are informed by practice by taking care of a lot of people who have gone through the transition period from being an adolescent to a young adult. Some of their general recommendations is that the patient should be engaged in planning so that, basically that early on, you say like, hey, at some point in the future, at say age 18, we're going to try to maybe transition you hopefully to an adult practice if you're ready for that and wanted to get your thoughts about it. So make sure that we're sort of engaging with the teenager and getting their kind of their buy-in and their voice in all this. Often it's helpful to write out a transition plan so that you sort of, when somebody is young, 12, 13, 14, to say, this is how we expect things to go. And so they have sort of a mental map of where things are. It's good for us, the providers, to know and for the patients to know a little bit about their family history and what other relevance that might have in terms of their health problems in the family that might affect the individual as they get older. Often there's an attempt to try to help create resources or binders about somebody's either their own particular health condition or the surgeries and things they've had in the past. Electronic medical records are changing this because it's a little less onus on the person to say keep a paper chart of all the things that they've had done, but it's good to still have good awareness of what this is. And if there's an electronic resource that how to access it, and if you need to share it with somebody else, like if you're out on vacation somewhere and you go into an emergency room, and they don't have your records, what would you be able to tell them about your heart condition? Again, we kind of touched on a number of times reproductive counseling. Again, if people are going to get pregnant or start a family, what are the risks and benefits of that? Having some dimensions about the insurance and financial planning. It's thankfully, since the passage of the Affordable Care Act, a lot of people can stay on their parents' insurance until their mid-20s, but at some point, a lot of people are going to need to transition to their own health insurance. And then vocation, kind of how do you plan a career? A lot of people with congenital heart disease can do much any kind of job that's out there that they're otherwise qualified for. But there may be some health conditions that might make it challenging to do certain jobs. And so, if you've had a history of passing out, airline pilot is probably not something you should probably aspire to do. And so there are some different things that we should try to help steer people so they can get appropriate career counseling down the road. So in terms of how it's recommended to start the process, so usually it's saying to start at least in an overview sort of way around age 12, and to encourage the child to start to co-sign forms and be involved in the healthcare process, to have them start taking along some of the role. The parent's still at this point ultimately in charge, but to have them kind of buy in along with it too. And again, providing that that plan for a transition of care and ultimate transfer is important, and to focus on health promotion, so and prevention of secondary problems, so that we try to focus on not only what to look out for, but also to kind of like how can you be the healthiest version of you and try to keep it in a positive light too. And how to watch out for, a lot of people as they get older are going to, at least try alcohol, some people might try drugs, and what kind of things for some people with some heart conditions that may carry more risk than it does for the average teenager. And ultimately, we want to try to help them be equipped to be able to select an adult care provider, especially if they end up moving away because of a job or college, and how to, know to find somebody. Transition also their primary care, maybe ultimately. Some people might see a family medicine doctor or an internal medicine pediatrics provider who's comfortable seeing somebody across the whole age span. But if they see a general pediatrician, at some point they might need to transition their primary care to, and how to help get health records to that new doctor, and again, to have the portable medical records and care plans. So, when we do things in medicine nowadays, there's sort of like, well, for a long time there was sort of presumption, hey, let's do this because it makes sense. And for a lot of things in medicine, that'll hold true, but then there's some things that we think help, but then we're not exactly sure they do. And so, like, what evidence is out there right now that interventions already exist? And the Cochrane Library, or the Cochrane database reviews, is where researchers who are very thoughtful will look at all of the research that's out there and try to say, is the quality of the research good? Is this something that every practice should be doing? And as of a review from a few years ago, they basically found that there were only about 4 studies where they had really good design of the research study, and the follow-up was relatively short, like it followed people kind of months to a year afterwards. And basically saying that, unfortunately, these short-term projects, though they might be a little bit helpful, don't really follow people long enough to kind of know if it's really helpful, as transition is a lengthy process. And so it's so that, you can educate people, and that helps them be a little bit better in the near term about taking care of themselves and having confidence in their care. But, whether that leads to bigger gains down term is sort of a bit of unknown. And so just so they can't draw any firm conclusions about the evaluation. And they were recommending there's further research. Well, when we try to think about research, it's a little bit tough about what are we trying to do? What are we really trying to achieve? Well, I think we'd like to try to make sure that there's a successful transfer. We want to try to make sure that people don't fall out of care. I think we'd like to be able to know that we're actually, if we're teaching people and trying to help them learn, that we're helping them acquire skills. And I think an important part of this is hopefully to help them feel comfortable with their health condition and what to look out for, and that we're hopefully increasing their confidence and decreasing their anxiety rather than the other way around. And it can be challenging because I think earlier on, when I would try to educate people about what might go wrong with their heart, that could take somebody who's actually fairly happy and confident and make them really worried about something. And that's not the intent. The intent is to hopefully give people like ideas of what to look out for. And if those things aren't going on, to hopefully that they can feel confident about their health. And ultimately, what we really, really want to do is prevent deterioration in health or having them being hospitalized or, God forbid, dying. But what the challenges, is that, how do we define a successful transfer? Is it just showing up to that first visit with the adult provider, or is it staying with them for a few years and making sure that really sticks? In terms of when we're looking at skills, it's much easier to ask people like, hey, do you think you can do it versus can you really do it? So like if I ask somebody in the office, if your medicine ran out and you need a refill, can you fill it? And they say yes, that might say that's they think they feel confident about it. But have they ever had to do it? Can they actually do that? It's a little harder to do that. You'd actually have to design something to measure, can they really do it? And then anxiety and depression, when we try to think about people's comfort and their anxiety about their condition, well, a lot of people, independent of any kind of heart condition, have issues with anxiety and depression. So it's sometimes hard to tease out what might be kind of typical changes of adolescence and mental health issues that anybody might go through versus what maybe, the congenital heart issue is kind of weighing harder on them. And thankfully, hard endpoints like being admitted to a hospital for a preventable problem and severe things are relatively infrequent. So they don't thankfully happen that often to adolescents. So it's hard to know if things are infrequent. Are you really making a difference if only it happens to rarely? That and you'd really love to have years and years and years of research data, but that sort of research becomes really challenging to do an intervention today and know that you're going to be keeping somebody well 10 years from now. It's hard to have that kind of long-term scope. So one of the researchers who is, I think, kind of taking a lead in this, that I think it's good to just talk about, Andrew MacKay and colleagues, he trained at Boston Children's, but currently is at the University of Alberta in Canada, has done a couple of different trials on healthcare transitions for adolescents. And the first one was called the Chapter 1 study, where he looked at patients who were 15 to 17 years of age with moderate or complex congenital heart disease or cardiomyopathy, a heart muscle problem where the muscle's abnormal and less efficient. And they did a 1-hour nurse-led one-on-one teaching session versus just somebody coming into the office and not getting this extra added hour of teaching. And they used questionnaires, the track tool, which I'll talk about in a second, the My Heart School, and seeing how people did before and afterwards. So they basically, in that hour, they talked about kind of trying to put a health passport together of, this is your heart condition, this is what to watch out for. They talked a little bit about how their heart was and potential future complications, and talked about third-party or things in the third person about what might relate to, say, being sexually active as a young person or substance abuse issues and all sorts of other things within that hour. And then they use this track thing, is that basically it's a series of questions like saying, ask all these different dimensions like, do you know how to fill a prescription if you need to? No, I don't know how, all the way to yes, I always do this and I know when I need to. And it covers a number of different domains about appointment keeping, tracking health issues, talking with providers, and managing daily activities. And the My Heart scale is a little bit more about, do you know the specifics of your heart condition and like what procedures you've had, what are your medications, when to follow up, do you need to take antibiotics before dental work, which we abbreviate as SBE or spontaneous bacterial endocarditis prophylaxis. And what this chart shows is the green is the people who got the extra hour, and the red is the people who just got the standard care and didn't get the extra hour of education. This is looking at their track and saying like how ready do they feel for transitioning. And this looks at enrollment at the beginning of the study, 1 month later and 6 months later. And by 6 months later, you can see these patients are scoring higher on it that got the extra hour of education versus those that didn't. There's a little bit of overlap here, but on average, more patients felt more confident in their ability to self-manage as time went on. And in terms of their understanding in their heart disease, again, both groups started pretty equally at the beginning, but a month out and 2 months out, the folks who got that extra hour of education felt much more, they scored better on do they understand their heart disease better. He and his colleagues later followed this up with the Chapters 2 studies, where this looked at 120 16 to 17-year-old at 2 different hospital sites. And this was 2 1-hour sessions between a cardiology nurse and a study participant. And this time they were not only looking like, hey, how do you do on a survey, but do these patients actually get to an adult cardiac provider? And then how are they coming in on time, or is there excess time? Are they running late a year to getting checked out? And they also did the same things where they said like, hey, do you need to get, how you do on the survey questions, and then follow up, do they need any kind of surgery or anything else? And they followed people again at the beginning, 1 month, 6 months, 12 months, and then a year and a half later, and then finally a chart review 2 years at the end of the study. And what this graph shows is this is saying like, do people come into that first appointment with their adult provider on time? And the light blue are the people who got the extra effort, extra education, and the pink is the people who didn't. And then this is looking at excess months until they showed up with their adult provider. No group 100%, not everybody in either group got there, but the light blue group, you're looking at much more like 9 months or less of people who actually got into there. So within kind of a year and a half, they were in the adult practice, whereas the people that didn't, it was up to 20 months later before they finally got into care. So it did seem like emphasizing this and doing some extra education actually did make it more likely that people would end up in an adult clinic on time. And then this is showing some of the same sort of stuff. I won't go through all the details, but then basically people felt more confident and better, knew their hearts better. This up here in the upper left side of the screen is that kind of like, do you understand your heart condition better? And the blue is the people who got the extra education. And as a group, they generally felt like they understood their heart better than the people who didn't get that. So there's a Chapter 3 study that's going on right now, and it's looking at starting a little bit younger. It's looking at 13 to 14-year-olds in a 60-minute interaction. They're getting their healthcare passports together and talking about things, but they also watch videos. This is actually watching them showing a scenario where somebody goes into a pharmacist and they don't have their prescription. And the first time around, they say like, I don't know what to do. And they just walk out. And the second time is they go up to the pharmacist and they have a conversation about what next steps they could do to try to figure things out to get that medicine refill. So that's, and they're going to recheck these same sort of things. And then, but we're all looking forward. I think the hope is that if there's research that prove that these sort of interventions make a difference, is that will help gain momentum in the field for to do it. It may also help for, insurance companies and the government, who ultimately kind of fund a lot of the healthcare expenditures in this country, to say, if this actually makes a difference, then this is something that's worth putting resources behind. And so that hopefully that we'll have more resources than time, because to have a nurse to spend an hour with a patient is a great thing, but it's not free. And so we have to find a way, if we prove that it makes an improvement and betterment, then it'll be something that we can more easily justify moving forward. But as it stands today, if there's not somebody who has access to a nurse to give them extra education, where are things that people can do right now to learn more on their own? Well, there's some great things on the web. So not specific to congenital heart care, but kind of broadly to a lot of these adolescent health issues that can lead into adulthood. There's a organization where Got Transition, I believe .org, yeah, and they have a lot of resources for both providers. There's clinician elements, as well as for young people and their families, to try to help transitioning their care from a pediatric setting to an adult group, and how to make that as smooth and as robust as possible. There is a website called iHeartChange, which is about is more specific to congenital heart issues, and it does all sorts of domains about adult care and coping and taking charge of your health, connecting with other patients. They redid their website recently, so this is what it looks like now, but it doesn't quite have as at a glance all the different things they talk about, but it's a little bit slicker and more modern looking. So that's iHeartChange.org, and it's a website that's free to sign up with. And then the other thing I think is good to know about is the Adult Congenital Heart Association. So this is a group of individuals that actually originally started in Boston, but now headquartered in Philadelphia, and it's a national organization. And it started with patients who themselves, they were born with a heart condition, sometimes their loved ones, and grew to be the doctors and nurses that help take care of them. They've got a nationwide clinic directory of all the adult congenital heart clinics in the US and Canada. And they've got a number of informational webinars and other things on all sorts of topics, not just transition sort of stuff. There's a little bit about transition. There's a lot about all sorts of implications for, say, insurance needs and again, family planning and different things on specific heart conditions. So these are some of the different resources that are out there. So that concludes kind of the prepared stuff that I put together, but I'm very happy to try to answer questions that anybody has. And I thank everybody who's been here listening to the talk.
Thank you so much, Dr. Lern, for this helpful presentation. We are now going to open up the session for questions and answers. So if you have any questions for Dr. Lern, feel free to use the chat feature located at the bottom of your screen and ask your questions. We did have a question, Dr. Lern, earlier on in the session about resources, which you happily shared. Just in case people weren't able to catch them all, would you be able to reiterate those online resources again?
Yeah, let me go through. I may have gone through a little quickly. Let me get my screen share back up again. Okay, so a little bit more slowly. So gottransition.org, and if you just, again, in any search engine, Google and just put in Got Transition, the site will probably come up. And this, it's a federally funded resource. So there's an organization that studies transition care issues, again, for a lot of things. So it could be people who have, again, children or adolescents who have type 1 diabetes who are transitioning to adulthood, cystic fibrosis, other sorts of not necessarily heart conditions, but some of these kind of common threads. And we all try to learn best practices from each other, but there's a little bit of differences. People who have diabetes obviously have to take, at least type 1 diabetics have to take insulin every day. And so that's very intensive. Most heart conditions are not that day-to-day intensive, but sometimes they're more sporadic in what they need. But anyway, this site is really well, it's got a lot of resources. It may not be always specific to the individual health condition, but it has a lot of the broader themes on kind of growing up with a chronic health condition. iHeartChange is the site that's a little bit more heart specific. It came out of, I believe, the University of Toronto originally, but there are multiple hospitals that sort of support and contribute to this. And this is their new, but again, it's iHeartChange.org. And there's a way to sign up. They also have, I believe if you sign up for it, if you complete all the educational things, they sort of give you like a little, virtual diploma for completing everything. So try to go through all those things. But it's mostly just, again, something that people can do at their own time, at their own pace. and read on their own. And then the Adult Congenital Heart Association, ACHA.org was already taken, so they are ACHAheart.org. But if you can remember, like Adult Congenital Heart Association, if you just put that in a search, this will come up. So
Great, thank you so much. So we'll give it a couple more minutes to see if we have any other additional questions. So we have a question. How best can we reach the adolescent CHD patients in rural communities who do not have access to proper care? Would it be through their primary care physician?
Yeah, I think that's a great question, because I think that there are, to my knowledge, I don't think that there's a single adult congenital practice, say in the Dakotas, so North Dakota or South Dakota. And I'm in a clinic. I'm at the pediatric cardiology clinic from Mass General in Worcester, but I don't know exactly what is out in, say, Western Mass. So whether you live close to the Northeast, and there are places around the country where you might live in an urban environment, but might not be easy to get to some of these things. So there are people all over the country that need to hear some of this stuff. I think it's great for primary care doctors to be aware of this. At the same time, a lot of primary care doctors are super busy, and they are often seeing patients, and they often have 10 to 15 minutes to try to tackle a number of issues. And this sort of thing often requires more time. So I think that primary care doctors should be part of the equation, but I think it would probably be unfair to really busy primary care practices to expect them to have the resources to do all of this. I'm cautiously optimistic. And again, I think a lot of education, the doctors, absolutely, there's an onus on us to be good about explaining things clearly and making sure people understand things. But I think a lot of good education doesn't necessarily need an MD degree to give. And so I think having nurse educators who can try to help explain the nuances. And I will say, for people with, say, type 1 diabetes, and I keep bringing this up as an example, probably because they're one of the first groups, because there is a lot of intensive care around that. There are diabetic educators. There are people that are not physicians, but they know diabetes really, really well. And they have experience explaining the practical aspects of care to people. And so I think that maybe for folks who live in rural communities, that perhaps we should have, again, maybe if there's more research to support it's having a benefit, we could have, virtual or distance learning, educators for different health conditions to try to help people transition. Because I love for people to exist in their community, but again, if you're in a rural community and there's one or two people in the community that have congenital heart issues, and there may be more, but to have a resource person just for them may be tough. But I do think we should try to think about how can we make sure that we do not have people in rural communities sort of not get the benefit of these sorts of efforts. Because a lot of the adult congenital care is kind of centered at big kind of major medical centers and major metropolitan areas, and so there is often more robustness if you live close to one of these big centers.
Thank you. And we have another question. Who in the cardiology practice can address the mental health issues in adult CHD patients? Not all hospitals have social workers.
Yeah, no, that's true. I mean, I think that it's a lot of groups are fairly resource constrained, and I think it's challenging because I think if you're running a busy practice and you are taking care of a lot of patients and you're trying to make sure their heart is healthy, surely you care about the whole person, but do you feel like you have the time, the experience to do this? Now, I will say that a lot of primary care doctors are more familiar with mental health resources and primary prescribing, say, anxiety medications and antidepressants than they would have been, even 15, 20 years ago. So I think sometimes, where it would be unfair to expect a busy cardiac practice to have all the resources under their roof, but I think it's maybe a little more reasonable to try to identify who are providers in the areas that maybe people can go to, or what are the mental care resources. Because, if you do a one-time, search in your community or talk to a social worker once about like, well, hey, I know we don't have a social worker dedicated to us, but the broader hospital does. What would be the mental health resources that you would recommend as a first line? What are the numbers that you give people? And if you have that as a handout that you can give people as necessary, that may handle a certain part of it. And then, if you know what the resources are in your community when that isn't sufficient, or somebody's a little bit more in crisis, that again, you don't have to take it on all yourself, but to know what those resources are. And to be honest, I'm a little spoiled because I can talk to a social worker and I don't have to commit that stuff to memory. But, if you're a small practice, if you have the bandwidth to at least just find out what those entry-level resources are to point somebody in that direction, I think that's a good place to start.
Thank you.
Are there any other questions or?
We'll give it another minute, and if not, we can end early. While we wait, any final thoughts you'd like to share with the audience?
So no, I mean, I think this is a area where I think that there is a lot of neat things happening. I think there needs to be a lot more growth and investment in it. So I think stay tuned. And I honestly think that, I said there was an email from somebody that, from CochraneCHD.org. There are other patient advocacy organizations out there. And I think that community resources, I mentioned the Adult Congenital Heart Association is one, but there are a number of ones out there, Mended Little Hearts. There's other ones that are escaping my mind at the moment. But I think getting involved, one, I think it's helpful because it's less isolating. A lot of people, even though they may have remember when they went through surgery or in the hospital, there are other people around them. They go back into their home, their community, and nobody else that they know of has a scar on their chest that young of age. And so I think, being part of the broader groups can, one, make you feel like there's a little bit of community around you. Two, I think the communities are coordinating. It really helps with advocacy. So right now it's a little bit different because the, probably with the pandemic, but once a year there's an advocacy day in Washington, D.C., where groups like Mended Little Heart, Conquering CHD, the Adult Congenital Heart Association, and I know that there's another one that's killing me that I can't remember the name of it, would go to DC and they would have meetings with offices from representatives and senators around the country. And it was very powerful to have somebody go into a legislator's office and you have a child, maybe the child with the parents of the child with congenital heart disease, an adult person who is 20 years later in life dealing with it, a doctor and a nurse, and we're all saying like congenital heart disease is a condition that affects a lot of people, and let's not to say that anybody should get any less funding, but like cystic fibrosis has a lot of visibility and a lot of funding, and congenital heart disease as a group actually affects more people and doesn't have quite as much visibility. And so we're at, both should be funded, but, sometimes going out and saying like, hey, we need more research funding. We need more funding for these sort of resources. It's a great thing. I think it's more powerful when we have those people come together. And I think for the people that come do it, I felt it was rewarding because I felt that, hey, if we're making a difference. So long story short, things are not where they need to be yet. And I'm optimistic we're getting there, but I think the more engaged, the broader patient community could be, the more that they'll push us all to being better and more robust for the future.
Absolutely. All right, so I think that's all that we have for today. We don't see any of the questions in the chat box. So I wanted to thank everyone for joining us today. Hopefully you found today's session helpful. As I mentioned, if you're interested in viewing a recording of today's session, feel free to visit the Blum Center website at massgeneral.org/Blum-Center. Thank you everyone for joining us today. And Dr. Learn, thank you so much for a helpful presentation today.
You're welcome.
Take care, everyone.